This is Anne DeGheest, and this is my clinical update on June the 25th, 2021. And if you have missed my first video, you want to take a quick look. We have a problem in South America. Unfortunately, South America is having a problem with the variants there that came from Brazil and is able to bypass a lot of the Chinese vaccinations. US is doing fantastic, so that's a very upbeat report, so you probably want to get some good news there. Today, we're going to discuss about the fact that, unfortunately, in the US, the Delta variant is starting to spread and becoming the dominant variant in the US, and unvaccinated people are still at risk. There's some new information you want to know about for young men who get the mRNA vaccine. There's a very low probability, but you may have cardiac symptoms there, and you want immediately to be seeing a doctor if that happens. And then some very interesting data published by Pfizer using real-world evidence from Israel on the effectiveness of their vaccine, and some data on the brain and COVID. So let's go through it. This is a cool picture of the virus. You can see in the little green dots attacking a cell. So some interesting data I digged up. It turns out the first coronavirus came in 1889, and that was called the Russian influenza. It killed 1 million people, and it jumped from the cow to the human, in this case, not from a bat, but from the cow. And it came as a mutation with a common cold called the OC43 there. And it is very similar to what we're seeing with COVID-19. A lot of the patients suffer central nervous system damage. They had depression, psychosis, insomnia. Men were much more vulnerable than the women. A famous victim was the son of Queen Victoria, grandson, I should say, who unfortunately died very quickly of that disease there. And it has the same pattern there, which means it returned the second year and caused nearly twice as many deaths as the first year. And unfortunately came up for third year. So we're not out of the woods yet. So more data on the disease. There's a lot of sign that there is brain inflammation when you're in the acute phase of the COVID infection. And there was a study that just came out from Stanford when they look at the pathology of a disease patient versus normal brain. And what they saw is that they don't see the virus right into the brain, where other studies have shown that they could see it. So there's a bit of difference there. But they see clearly that it's linked to chronic brain disorder like cognition, schizophrenia, and depression. And they also see macrophage, which is a response of the body for clearly an infection in the brain, and clear distress of the cerebral cortex in the memory, in the reasoning, which is all this brain fog that we've been hearing from the long COVID patient. What's a bit worrisome is that it seems to have the same pattern that neurodegenerative conditions such as Alzheimer. In parallel, another study came out in the Cleveland Clinic, where they also were able to confirm that the virus is having similar biomarkers in the brain that you see related to Alzheimer's. So there's clearly neurodegeneration that's being triggered. And this is brand new, which is 20% of the population has a genetic mutation called ApoE4, which puts you at much higher risk of Alzheimer's. And it looks like those people have lower antiviral defenses against COVID. So they're at significantly higher risk for having a more severe infection when they get exposed to COVID. So if you have one of that mutation, you probably need to make sure you're vaccinated and still use some precautions there, because it's pretty significant difference. Another thing that also came out is a study from 23andMe, and they look at 1 million people, and they discovered that 68% of those patients there who got COVID lost their sense of smell and taste. This is where it becomes interesting. There is a variant, a gene mutation on chromosome 4 that is kind of linked to the olfactory genes. And this is the one where that you have different tastes when you take ice cream there. If you have that mutation, you're 11% chance, higher chances to lose your sense of smell and taste. So there's clearly a genetic component there that may be tied to the fact that you lose the sense of smell and taste. Why is that important? Is that another tidbit came from another direction. And you may know that some of us have a different way of testing bitterness. So if you look at the population, it's pretty much 1/3 for people are normal taster, super taster, i.e. very sensitive to the bitter taste, and people like me who don't really taste the bitterness like other people. And what they've come up is that, which is a little bit worrisome, is that if you're a non-taster, i.e. you don't taste bitterness like other people, so you like tonic water, for example, you have a 10 times higher chances to get COVID and a 4 times higher chance to be hospitalized. And this is where it gets a little bit scary there, because those people there who are the non-tasters there, they stay in the hospital 23 days, i.e. they're pretty serious and very sick there, versus 13 days on the average. And then the people, a super taster, they only stay in the hospital for 5 days. So very big difference there. And they believe it's linked to this, some of this receptor that we have, which is linked to sinusoidal innate immunity there. So there's clearly something going on in a sense of taste and smell, and the risk of you developing a much more complex COVID there. So again, if you're aware of it, that means you're at higher risk. So the good news, the US government has just announced they're going to be investing $3 billion to develop COVID antiviral. These are drugs that you use when you get infected. And then in the process of accelerating existing trials already in process, and that's Merck, Pfizer, and Gilead, who are already doing clinical trials there. The FDA has already cleared 3 monoclonal antibodies, but unfortunately, you have to use intravenous injections there. So we need to try to find drugs that doesn't require an IV injection in a hospital. So there's around $300 million for research and lab supports, $1 billion to speed up the clinical, and $700 million for the manufacturing process there. So hopefully we can get an arsenal of new drugs to treat people in the next wave that's coming at us. So let's talk about what's called the correlate of immunity protection. So you can get immunity from your innate immunity, which is your natural antibodies and T cells. And then you have what's called the adaptive immunity, which comes from a natural there. So your mom, while you were pregnant, they passed on some of the antibodies, or you have an infection, you build the antibodies, or you basically get the vaccine, and then you basically have the immunization there. So to be clear, we don't fully understand how all these pieces works, but there's some interesting data that just came out. One thing is that if you have an autoimmune disorders, we know you don't produce as many antibody, but does that mean that the whole immunity protection is not as good? Because remember, we have T cells and a whole bunch of other things. We don't really know. But those people are now getting 3rd shots, just to basically boost their response system there. We also know that a lot of the mRNA companies like Moderna and Pfizer's are developing in that booster shot, the 3rd shot that we may get this winter, a whole bunch of different constructs that go beyond just the spike protein, which is the attachment there. So hopefully we'll have a broader protection in case the virus mutates. Why is that important there, that when you get that 2nd dose, you feel bad? Well, it turns out if you feel bad, that's good news. It's good news because it means your immune system kicks in, and around 60% of people have side effects after the 2nd dose, and it's now being linked to what's called interferon, which is the body inbuilt immune stimulators, and this IFN1. And so clearly all the studies shows a direct correlation between the type 1 interferon and the fact that it builds all the antibodies. And we've seen the same thing with other type of vaccines, like the hepatitis B and C, the multiple sclerosis, are totally linked to that production of interferon that basically tied to basically a stronger protection there. And we know historically that interferon generation naturally is stronger in female than men, which may explain why we see some different response, and in younger people than older people there. So a lot of validation is starting to come out in these studies. So let's take a look at the antibody response after mRNA. This is interesting data. Naive means you did not get infected and you got 2 doses. So if you got the 1st dose, you get some antibodies and you got significantly more in the 2nd dose. If you had been infected, it looks like you get as many antibody after the 1st dose and the 2nd dose. And in some European countries right now, they only recommend 1 dose of an mRNA if you have been infected to basically boost up your antibodies. But look at the difference of the antibody. I mean, it's significantly higher. So you really want to make sure you get the vaccine if you had been infected. And clearly, we also know that if you have a mild case of COVID, you may have a tiny bit of antibodies, but that may not protect you from being reinfected versus a severe there. So what does that mean? There, interesting data came out about what's called hybrid immunity. And what it shows, this is your natural immunity, which is a combination of your B cells, the antibody, and the T cells. If you basically get a vaccine immunity, you get slightly more than if you had the infection. And if you get what's called a hybrid, which is you get that infection and then you get the booster there, you can get 25 to 100 times more antibodies. And so there's a belief now that what we want to do is to have the booster shot, the third shot, to be from a different vaccine. So we can try to simulate that breadth that we're getting with the hybrid immunity there. And we saw the same thing with shingles vaccines. In the shingle vaccines, when you give that vaccine to people who had been infected with varicella, you show a much stronger response and much stronger protection for people who had been infected with 97% effectiveness. So I suspect that it's not decided by the US yet, but I think people are really going in that direction. The third shot you're going to get is from a different vendor than the first two shots that you got. So this is important there. We have discovered a very rare case of what's called myocarditis. Myocarditis is an inflammation of the heart muscles and the lining around the heart. It's pretty rare because it's happening only 12 cases per million after the second dose. But it's very targeted to young men between the age of 12 to 39 years old, and it happens on the average within the first 5 days after the second dose. Now, the good news, it's treatable. If quickly recognized, there has been no death so far. It's a very rare risk, so pretty much all the major public health agencies recommend that you still get vaccinated because the benefit of the vaccination totally outweigh that very rare case. But let's look at the data. So if you look at female and the incidence for young people there, it's probably 1/10 of what's happening to men. So it's clearly affecting more men than women. And when you look at the type of symptoms you need to look for is chest pain, dyspnea, which is a problem, breathing, a change in arrhythmia, the ST or the T waveform. And also if you do a blood test, you can see an elevation of the cardiac enzyme. So if anybody that you know is a young man who is after he got the second shot of vaccine is complaining or not feeling well, you really want them to be checked. You don't have to go to the emergency room, but you really want them to be checked because it's treatable. Now you can see that it's really happening and after the second dose there in that young population there. So clearly a peak between 16 to probably 24 years old. And it's happening in the first 4 to 5 days. Now there are some cases there where it happens afterwards, but you can really see that you just need to keep an eye for a few days after the second dose. So because of the alphabet soup of all these variants, the B117 and all of that, the authorities have decided to change the way we call the variants. And they only are doing this for what's called the variant of concern, i.e. the one that are considered to be dangerous. So now what used to be called the British variants, the UK variant, is now called the Alpha. It's extremely more infectious. And then we have the Beta, which came from South Africa, the Gamma from Brazil, and then the famous Delta, which is the one we're going to spend more time on, which is the one from India. And the good news is you can see the effectiveness. The mRNA is working on all those variants. But look, some of them, like Sinovac and Sinopharm, are not working with the Delta variant. And Novavax is also not working there. And so we are lucky in the US that we have access to the mRNAs. But in the rest of the world, you're going to see in the first video that it's creating a problem in South America because these variants and the Brazilian variants are creating havoc. This is an analysis that shows in green this Delta variant, which you can see are pretty much now taken over the UK. This is what used to be called the UK variant there. So we're clearly taking over. It's happening. It's now 20% of the US in a very short period of time. It's expected by August to be the dominant variant in the US. You can see it's in India. And we want to talk about the fact there's a new mutation of that Delta variant. And for example, in Belgium, it's starting to also emerge. So that variant is expected to take over the world in the next 4 to 8 weeks. In the US, the P1 variant, which is unfortunately that nasty variant from Brazil that's resistant and decrease the response of the vaccine, is already 16%. You can see it's starting to grow. And the P1 over here. And then unfortunately, we are starting to see the Delta in the variant is around 20% and growing pretty quickly there. So, whoops, sorry. You go back. So why is that important? The Delta variant is 2.5 times more infectious than the original SARS, the one from Wuhan. The Gamma from Brazil is 2 times more infections than. This is why it's creating so much havoc in the world. The Alpha there was 50% more infections there. So we see this virus mutating to get more and more and more infectious. That's the way it's going. And we may have another variant coming in the next 3 to 6 months. Why is that important? If you look at the first variant, one person infected on the average around 3 people there. So in order for us to get herd immunity, we only need 67% of the population to have some protection. As we move to this Delta variant, one person now infects 6 people. So it's a huge difference. And therefore, we need a much higher level of herd immunity of around 83% to stop the spread of the variant. So it is having an impact. That's why it is still spreading in the unvaccinated population. To make things even more complicated, now there's a Lambda variant, which we don't know too much about yet, but it's coming out of South America. And that may explain some of the outbreak we see in South America there. It's probably a mutation that's coming out of the Brazil variant. In the US, let's talk a bit more about the Delta. It's also associated with hearing loss, which we hadn't really seen that symptoms with some of the original variants there. In Israel, this is a little bit worrisome, and it's only early data there, but 90% of the new infection in Israel were the Delta, and 50% of those patients had been vaccinated with Pfizer. So there are breakthrough cases with the Delta variant. It is a very low number. They only do 200 per day there. But I think what's nice about Israel is that they do the genomics of most of their cases there. As a result of that, they are reevaluating lifting the lockdowns, and they basically push the opening of the borders from July 1st to August the 1st. The good news is that the vaccine are preventing severe case and hospitalization, but it may not be preventing infection. And so that's something we need to learn as we go. And then to make things more complicated, we now have a Delta Plus, which is a mutation of the Delta, which just has emerged in the last few weeks. It has that K4179 that's being mutated in addition to the traditional one. And there's a worry that it may diminish vaccine and antibody treatment there. So again, this thing continuously mutate in a way that's more infectious and try to evade the vaccine. So keep an eye on that one. So what's happening with the Delta variant? It has 12 mutations that are different. Most of them on the spike, which is the way the virus is attaching to your ACE2 receptors there. And you can see, if you're interested there, the difference between the B117, which is the British one, and some of these new mutations that have emerged with different part of the spikes that have mutated there. So just to make things a bit more complicated. Why is that important there? Because we believe that there are now, which is the infection rate of this Delta is between 5 to 8. To give you an idea, the original Wuhan was like between 1.5 to 2. What that means is, this is from the top physician at UCSF, is that any unvaccinated people are at risk of getting infected this summer, and also more importantly, this winter. It's much more infectious there. This is the Delta compared to the original Wuhan. I can see the difference in the number of people are infecting there. It makes people sicker. And it also, you only have 33% protection if you had 1 dose of the vaccine. You absolutely, for that Delta variant, you need both doses to get the full protection, which is very different than what we have with Wuhan, where we had a much stronger protection with the 1 dose. So there's an expectation that we may get a surge this fall in the low vaccination part of the population there. So to summarize it, you have, against the Delta, if you have mRNA, you have 88% protection, not 94, but 88. If you have the 2 doses, if you only have 1 dose, you are not really protected. The J&J is only 60%, and AstraZeneca is only 60%. And then we've seen earlier that the Chinese have a lower vaccination effectiveness also there. So that Delta variant is dangerous. So another report came out of Scotland there, and what they show is that it will double the risk of hospitalization if you did get infected, and that the protection from the Pfizer has dropped from 92% in their cases to 79%. in the UK. They also show that the vaccine is protecting you against hospitalization. And so just be aware that AstraZeneca is significantly less effective. It's only 60% if you're in Europe and you're listening to this. So this is a busy slide for people who are into data there, but this is basically keeping track of the antibodies. And we know antibodies are decreasing with age. You need at least 2 doses to get the protection there. And you can see the difference as you're aging there. This is very interesting data. You can see that as we're aging, if you're 30 over here versus 60, you have a significant drop in your antibodies against all these different variants there. So, and one number doesn't mean everybody. So just be aware, use common sense. So quick vaccine update. There was a big failure from a company called Curevac, which was a German company, and they only showed 47% efficacy, which is not enough to be approved by the European or the World Health Organization. The EU had purchased 405 million doses, so that's a problem there because they're going to get a hold there. And they're now working on a second generation, but it's not going to happen until 2022. Sinovac, as I've explained a little bit earlier there, is using an inactivated COVID virus, and it only shows 62% efficacy within Brazil. And that explains the problem that Chile is having, because 93% of people in Chile have been vaccinated with Sinovac, and it's pretty clear that they have only a 54% efficacy after the second dose. In Indonesia, which is also using the Sinovac, they're having a massive outbreak, despite the fact that a lot of people are vaccinated, including people who are vaccinated. So clearly, vaccines are very different, and you really need to know which one you're getting. And 33% of new cases are people who are fully vaccinated. So the Chinese vaccine is not protective against the Delta variant. Another Chinese vaccine is called Sinopharm. They claim efficacy of 78%, but they're having outbreak despite high vaccination rate in the Seychelles and Mongolia. So clearly, some of these mutations there are evading the vaccine. And Bahrain is now offering booster shot using the Pfizer BioNTech just because there's not enough protection with the Chinese vaccine. A new vaccine from Cuba, they made their own vaccine called Abdala, requires 3 doses. They claim 92% efficacy after 3 doses, but there's not enough published data for us to really know if it's true or not. This is some slides. I was on a webinar organized by Pfizer sharing what's called real world evidence as opposed to clinical trials. And they made a contract with Israel, if you remember last year, to provide Israel with a more expensive price per drug of the vaccine to basically vaccinate the whole population so they could do analysis on their population. And so what they show was that the population of Israel is around 9 million people. They have the highest vaccination rate in the world. And they show that as soon as they start vaccinating, you can see that the number of infections have dropped drastically. And the effectiveness in COVID cases in the hospitals and all of that has been stunning, higher than the clinical efficacy that they show in clinical trials. So 95, 97%. So fantastic news, because typically in real world evidence, you see lower data. In this case, we see higher data there. And clearly you can see the impact on first dose versus second dose in different age groups. Of course, very, very focused on the older population over the age of 65 years old. This is, for example, in the dots is the unvaccinated versus the vaccinated. You can see there's still some breakthrough cases, but not too much. It's very low. But most of the cases now in Israel are people who are unvaccinated. Same thing for the hospitalization rate is for people who are unvaccinated, end up in the hospital there. And this is the mortality all tied there. So the vaccine is effective, and this is probably one of the best cases. You can really see the drastic drop in the daily new cases after they reach this inflection point of a herd immunity of over, around 70% of the adult population. So these are all great news. So please stay positive and get vaccinated. And I'll see you in a month. And if you haven't seen my first video, please take a look at the epidemiology and what's happening in South America. Be safe and smile.